Good morning. My name is Nancy Giacolone, and with me today is Allison DePaoli. You have probably seen us both on our own individual podcasts, but occasionally we like to come together and do one on topics that we both feel passionately about. So today we're calling it What in the Healthcare is Going On? As professionals in the healthcare benefits area, we're no strangers to the intricacies of navigating the healthcare system. However, our expertise was put to the test in ways we never expected when we found ourselves on the other side of the healthcare experience. As many of you may know, Allison recently faced a very personal journey dealing with end of life care for her father. This experience brought to light the significant challenges involved in communication and the struggle to ensure that his and his family's wishes were respected and understood. On my end, I found myself in the patient's shoes, undergoing what's typically seen as a straightforward medical procedure, a total hip replacement. But as we both discovered, when it's your health or that of a loved one on the line, routine takes on a whole new meaning. So I want to kick it off this morning by starting with Allison, because her father recently passed at the end of 2023, and she was his advocate during this journey. And there were challenges that she never expected to encounter. And I'd like you to kind of walk the audience through your experience a little bit.
So I'm so glad to do this for you today. I think that we both thought we could manage the medical system, and we were pretty managed. And I'm also pretty sure that neither one of us really liked that experience. So, my father was older and he was declining. And I think that's a normal part of life, right? Parents age, nobody gets out alive. But when he had a trauma, he fell at home, and it was amazing to me how the machine just literally came at our family, and it was very, very hard to stop the machine. And I know, doctors are some of the most trusted people in the medical system, and often with very good reason. I will tell you that trauma care, as I was informed by a trauma nurse, is actually very simple. There's a very simple recipe for what to do and what not to do, but that recipe discounts entirely the patient and the patient's family. And I spent a week on a trauma floor, and there were families on either side of us. And I watched what my family did, and I watched what the families on either side of us did, and it was very different. And the family on one side of us, their father was about the same age as mine, and he had also fallen. He had a brain bleed. Unfortunately, my father did not have that. He was in a lot of pain, and they did whatever the doctor told them to do. And 97 times out of 100, the doctor never talked to them, never even stopped to talk to them. Any instruction, any information was passed through the nurse. And I got to tell you, trauma nurses are a special breed. They are wonderful, but the doctors never stop. I literally stepped in front of doctors to talk to them. And I find that to be horrifying. I don't find that to be a respectful way to treat either patients or families. It has nothing to do with patients or families.
I think that's one of the reasons that you and I said we should talk about this publicly, because I don't know when healthcare became so impersonal. I'm not questioning the doctor's skills, the surgeon's skills, but your health and the health of your family, especially when you're going through a traumatic event, is personal, it's emotional, it's frightening, it's intimidating. And just a couple of minutes of grace would go so far.
Yes. And so because my father was on the trauma ward, the doctors are called something a little bit different. So the person responsible, the medical professional responsible for the floor, is called an intensivist. And then you have the trauma doctor on call. The trauma doctor on call in the hospital where my father was on call in the ER and on call in the trauma center. One doctor. And, sometimes that might be okay, and sometimes it's not okay. And what that means is that they have to be as efficient as possible. So the intensivist didn't even show up for rounds on Saturday. He called in, and literally the residents, they start at one end of the trauma center, and this was like a U-shaped trauma center with the nurses stations in the middle. They start on one end and they walk all the way around to the other end. The residents, the charge nurse, whoever is the trauma nurses had 2 patients in this particular hospital, would come out, say, do classical rounding. This is so and so. He's this, that. This is the diet. This is where we are today, and then they would move on to the next. On Saturday, the intensivist was on the telephone. At no point did an intensivist or a trauma doctor, except for the first night, step into the room where my father was. And I watched all around. They do not step into the rooms because they're not attached to the patient. They are interested in making sure they have taken their Hippocratic oath and keeping people alive at all costs, if that's what the patient wants or not, or even understands what is happening.
Let's spend a few minutes on that particular issue, because what you said is so important. They are dedicated to keeping the patient alive, regardless of the patient or the family's wishes. Mm-hmm. And let's talk about what that was like for you.
So in my particular situation, I don't live in South Florida where my father lived. I had to fly in, and I got off the plane, and there were a whole host of text messages. You need to call me as soon as you get off the plane. You need to call me as soon as you get off the plane. So-and-so is going to be calling you. You need to answer the phone from this kind of number, blah, blah, blah. And I was like, what happened? And so I wasn't even off the plane, and I was on the phone, and the first thing I was encountered was crying. And I just talked to Dr. Simon, who told me I have to come back to the hospital and we have to intubate your father, or he's not going to make it through the night. And I was like, oh no, no. And it's like, are you in agreement with that? And she's like, yes, but it's an emotional time. And so I called my stepsister. So my stepsister met her at the hospital, and they held these people off. They were on the phone with me telling me that they needed to intubate my father or he was going to die. Well, not that day. But I said no. And they were like, you can't do that. I was like, hell, I can't. I said, first off, there's a DNR. And second, I am the designated healthcare provider. I am the designated healthcare provider. Have one. It's the most important thing to have after a DNR, if that's what you wish. Even with that, I had to stop intubation every day. That was the first thing. We want to intubate your father. My father had pneumonia and was septic. It was getting worse and worse every day. And the only reason that I know it was getting worse and worse every day is I stepped into the rounds every day. If you didn't step into the rounds and know what to listen for, you weren't getting any information. I would have never known how sick he was. Why is that? That's terrible.
I don't know. And I find that to be an incredible disconnect in what should be a healthcare partnership. Mm-hmm. Because when you're a patient and you're working with a team of doctors and nurses and potentially family members, everybody needs to understand what's happening and what's going on so that informed decisions can be made that are best for everybody.
Correct. And the patient, best for the patient.
That's right. And I want to step into this. We're going to get back to this, but one of the areas I find distressing personally, again, having just gone through it myself, is the drug pushing that goes on in the hospital is insane. I had to say no so many times to drugs that they were giving me. And I said, well, I don't want this. And they're like, well, I said, I don't want this. And I would give them back, and they would be, they didn't know what to do with me.
Correct. because most people will do, they don't understand, they don't have any context, they don't know they can refuse, right? You know you can refuse, or at least ask a few questions about what it is that somebody is giving you. And you have resources to call if you need help and you don't understand something. Not everybody does. So you just do what you're told. If that's the best thing for you, Nancy, or not. And sometimes it's not. Sometimes it's the best thing for the hospital system. Sometimes it's the easiest thing for the staff. And sometimes it's just the procedure, which makes me bananas.
I think that it's just the procedure is a big thing. I can't tell you how many times, even to this day, when I talk to anybody around my condition, their first question is, what's your level of pain? You know, they want to show me the little chart with the happy face to all the way to the mad face. And I have explained to them multiple times, I'm not in pain, but I am uncomfortable. I have a level of discomfort. And every time they would put down whatever I would say as my pain level. I'm like, there's a difference between pain and discomfort. But I even asked them last time, I'm like, why are you recording that? I'm not in pain. They're like, well, we don't really have any other way to measure it. I said, it's not pain. It's a very different thing, and it should be treated differently, and it should be discussed differently.
I agree with that. And I think that we don't, in the way that the hospital systems work, there's not a lot of room for nuance. And in many instances, healthcare is very nuanced, right? Your level of discomfort may be my level of pain, right? Or vice versa. And is it an acute feeling? Is it a chronic feeling? Because I think those are different things as well. And, you know, we have an opioid epidemic in this country for a reason, right?
Yes.
Oh, you want this? Here.
I got a giant bottle of them, and I'm like, I think I took 3. And they're like, why aren't you taking those? I said, because I don't want to. Them. I don't need them. I don't need that. My pain is not so severe that I can't manage it on my own. I'm uncomfortable. I'm not in some sort of unmanageable pain. And we came up with this crazy little scale, and now that's the only way that they know how to communicate with you.
Correct. And I think we kind of went from this situation where you're just going to have to suck it up to now we're going to throw medication at you. And it's not just pain medication. It's all kinds of.
No, yes.
And we're going to over medicate people. And, you know, I had a client years and years ago who was diabetic, and we were talking about something. He said, oh, I have a great doctor. He doesn't make me exercise or ask me to watch what I eat. So I just eat what I want and he gives me medication. And I thought, that's not very good. Not my business, but you know, you can say no. You can take your health into your own hands, right? But when it is your health, if you are not a doctor or a skilled nurse or somebody with hospital experience in that situation, you don't understand the context, right? And what I think that one of the things that just about sent me over the edge is, well, you can take the ventilator off. And so I could put the ventilator on, decide I didn't want it anymore, and then feel like I was going to murder my father. That's great.
They actually said that to you?
Yeah. You can withdraw it at any time. I was like, why don't we just try to not do that? And, you know, I think one of the things, well, there were many things that upset me, but in my car ride, talking to doctors, talking to friends who are medical professionals, yelling, crying. They put in a central line, and I get there, and they're like, oh, well, maybe he's just septic. It's like, you don't think you should have checked that before you wanted to intubate him? And you know, that night at the hospital, they made me sign a DNR for him. And I brought the DNR the next day, and it still took until Monday for him to get a DNR bracelet, which means that everybody knows he's a DNR. And we had wonderful nurses. I cannot say enough good things about the nurses, but they are really regulated in what they can say, because I got to tell you, you can watch a body shut down. You can watch it. You can see it. They're, people, they're hypoxic. They have edema. You can see their oxygen levels dropping. You can see, if you're asking the right questions, you can see you can watch the organs shut down. And no nurse told me that your father is very sick. Would not say anything else but your father is very sick. It's like, really? I know I have blonde hair, but I think I can figure that out.
Do you think they're not allowed to?
I think they're not allowed to.
Well, if they're not allowed to, and you're in that type of situation, doesn't it seem reasonable that somebody who is allowed to should make a point of stopping by and explaining the situation?
It does seem reasonable, and I will tell you, in our experience, that did not happen. It did not happen from the trauma staff. We had when you become septic and you have pneumonia, you get another person added to your roster, and that is an infectious disease doctor.
Yep.
And the infectious disease doctor is the only one who ever said what he thought. And I caught him in the hallway one day, and I said, this is happening, and I think that this is problematic. And he looked at me and he said, yes, it is. And I must have had that look like, I don't know what to do, because I probably didn't know what to do at that very moment. And he said, if your father survives this, and there is a very slim chance that he will survive, he will be here for weeks. He will be in rehab for months, and he will regain maybe 20% of his function. That is the only man that ever told me the truth.
But wasn't that the most important piece of information you needed?
It was the most important piece of information I needed, and I had already received that information from people outside the hospital. But, I'm very fortunate. I work with a lot of primary care physicians. My father had a personal physician. I have friends who are as assertive as you and I are. And I was very, very fortunate to have those resources. But what if you're not?
Well, I think that speaks to the point that we both have resources. We both are assertive. We both ask questions. We both don't just accept what they're giving us. But even though we have all those advantages over the average patient or person inside the healthcare system, we still struggled.
Yes, we did.
And that really frightens me.
It frightens me. And you had a relatively routine procedure.
Yes.
Now, I don't know. They cut you open. They cut off part of your hip. They give you a new one, right? I mean, it seems kind of simple. I know you were up and about pretty quickly, but that's fairly traumatic for the body. And you were pretty much told you'll be fine in a couple of weeks. Has that been your experience?
It's not been my experience. I have found the whole process to be very frustrating because I haven't spent a lot of time inside. I have not spent a lot of time as a patient. I've never had a major surgery done like this before. So the fact that pre-op, I had to attend an online joint class with basically, no offense, a lot of 80-year-olds who are having knees or their third or fourth hip done. I sat through it. I listened. I got nothing out of it. When I went for my pre-op, they explained a procedure I was not having done. And I started getting very upset because I'm like, that's not what I was told was going to happen. Finally, it was sorted out and oops, that was not the right procedure. That gives you a lot of confidence.
Yeah.
You go into it. I have it. I was under anesthesia for a few hours and they wanted me to leave that evening. They wanted me out. And I wasn't ready to go because I was just still really under the effects of the anesthesia. By the
Recovered.
morning, by the morning, I was good. But the nurse, not the doctor, the nurse practitioner stopped by my office for, or my office, my room for about, I don't know, I'm going to say 30 seconds. And she said, "How are you doing this morning?" I said, "I'm a lot better this morning." She said, "See, you could have left last night," and walked out.
You know, my mother had an outpatient procedure, and I believe you were the first patient. And I think that is something very important for people to know, is that if you're going to have an outpatient surgery, you should always be the first patient scheduled.
Yeah.
And so for my mother's surgery, she was the second patient, and she was supposed to be in surgery by noon. She didn't get there till 3 o'clock in the afternoon, and they would not allow her to stay. And I fought and yelled and nope, 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 nope. I took her to my house and I took care of her. She stayed with me for a couple of days, which is fine. I'm happy to take care of my mother, but she should not have been released. She was completely incoherent. It
Yeah.
was really hard for me to get her into the car, out of the car, into the house. And, you know, I really don't have any steps. I don't have anything crazy. She's a normal sized person. She's easy to maneuver. She had a very challenging time. And that's not safe for people.
It's not safe and it's terrifying. When I was ready to be released, they have to take you through PT, which consists of you walking down a short stint of the hallway on your walker, and you're confronted with 4 steps that you have to walk up and down. And I immediately burst into tears when I saw those steps because I was already like, this was already so scary just to take a few steps. I got up and down, and it was fine. And they're like, "Okay." They had literally bagged up my stuff, had the wheelchair going, and they're wheeling me out to the car. Well, that's fine. It's all fine. It worked out fine, except all my bills are coming in now.
Mm-hmm.
Guess how much the charge was for the PT that I was provided?
Minimum about $300.
1,500.
Oh, even I'm shocked.
It was less than 5 minutes.
Yeah, see, when you know how to read the bills, conversations change.
Conversation.
I can't hear you. So while we're waiting for Nancy to get back, I'm going to say that this is an opportunity for you to review your medical bills before you pay them. So keep going. $1,500 charge.
What in the heck just happened?
I don't know, but we can hear you now. So if you have a medical procedure, you should never pay the first bill until you have an EOB from your insurance. If that is a private commercial carrier, if you're on Medicare, you have a Medicare Sup or a Medicare Advantage, whatever it is, do not pay a bill until you have an explanation of benefit and you can match it, because you'll see that you had not 5 minutes of PT and paid $1,500. And that's not good for anybody. It's not good for you, the patient. It's not good for insurance. It's not good for our healthcare system. The only people that benefits are, don't get me started.
Well, and another tip I would go along those lines is hospitals want to be paid up front. If you're having a routine procedure, they're like, "Oh, we checked it out and this is how much you owe." And again, knowing and as I do, I said, "Well, that's not going to be how much I owe because I've had all these other things done." And I said, I will give you a deposit, $1,000 or whatever, because I know that I will owe something, but that number is not right. And I'm not giving it to you because you're not going to be in any big hurry to give it back to me." So you can ask to not pay up front. And a lot of times the best option is just ask to be set up on a payment plan. Even if you don't intend to use the payment plan, your first bill won't be due till 30 plus days until after you've been released, and your claims will have gone through the insurance and you'll have a much clearer picture on how much you actually owe.
Yes.
So don't give them money unless you know it's right.
And that's not just hospitals, that's doctors also. I had a surgery about, I don't know, 11 or 12 years ago now, and it was relatively minor. And it was, I had to be there at 5 in the morning for my 7 a.m. surgery, and I think I was home at 11 o'clock. So not a big deal. And I paid the hospital, and then I paid I got a call from the doctor's billing office. I had been going to this particular doctor for 12 years. And the billing department told me I needed to pay them X. And I said, no, I've just paid the hospital. I'm not going to owe you that much money. I'm happy to pay you something. I think I'm going to owe you this. Can I just pay you this? No. I said, then we can cancel the surgery because I'm not paying you that. And they said, well, we'll have to check with the doctor. The doctor had to guarantee that if I didn't pay the bill, he would. Is that a way to treat your staff?
No, it's not. And it's not a way to treat people either. Unfortunately, everybody is so slotted into what their job is that they're going down their checklist and they don't understand all the other moving parts that are involved, especially when we're dealing with insurance on top of healthcare. If we're just dealing with healthcare, it's one thing. But when we throw in insurance and it gets really messy. I read an article this morning, actually. I was like, I need to bring this up. So apparently there is a lot of grocery stores and other retail places are starting to reconsider their commitment to the self-checkout kiosks because there's so much theft. They've lost so much money as a result of it. But the number one reason they're really reconsidering is because there's a 67% dissatisfaction level rating with any time somebody has to do all the work themselves, as opposed to going through a line and receiving assistance and making sure that everything is correct. So I think there's a direct correlation with what's happening there and what's happening in healthcare. Healthcare is not a self-service industry.
No, it is not.
And we've moved that direction.
And I also I had this conversation with a doctor friend of mine who works for a hospital system, and 70% of physicians now work for hospital systems, and we'll argue another day about why that's so bad for patients. But he has to meet an NPS score. So if a patient comes in and wants something and he doesn't give it to them, it's a problem for him. Now, I have problems on about 18 levels with that, but if this man is the doctor and his job is to take care of the patient, then maybe it shouldn't just be a free-for-all of what the patient wants. Maybe there should be a discussion about why that isn't the right thing, and this particular strategy, if it does or does not involve medication, and a lot of times it involves medication, is better for the patient. But a lot of times that doesn't happen because even physicians are completely overworked at this point, not just nurses, not just front desk staff, everybody, including physicians. I'm sorry, if you're seeing 12 patients an hour, you don't have time to argue with somebody or have a discussion about why they don't need this. And in this, I'm talking about all of those high cost medications that you and I look at and go, what's happening here? It's not necessary. If you can address somebody's whole health, then we could address a lot of the problem we have with the insurance and healthcare systems in the United States.
Well, if we got back to primary care doctors that were actually primary care doctors, hallelujah for DPC. Unfortunately, there's a lot of barriers for the average person to using DPC.
Absolutely.
So we know that's the goal, but it's not the reality for most people.
Correct.
A primary care doctor is supposed to be your health quarterback. They're supposed to be the one that keeps track of everything that's going on with you and oversees your overall health. But we don't really have that for the most part in the United States at the present time.
Only a very few people are fortunate enough to have that. And my father was one of those people. He had a private family physician who had been his physician for some time. And when I got to Florida and, my phone blew up and people were running and yelling and screaming and telling me my father was going to die overnight, he was the first call I made. And he told me, he said, well, He said, I have many patients your father's age and older who fall, and they have cracked ribs. And we intubate them for a week or 10 days, and we take them off, and they're fine. He said, you may want to reconsider that. He said, may want to reconsider that. He said, and I'm happy to talk with you about that. He said, but this is an acute situation, not a chronic situation. And I understand your father's wishes. So take a moment. He texted me at 6:45 the next morning. And the text said, I just spoke with the nurse. You may call me between 7 and 8. Now, I don't know about you, but when the physician calls you and says, you may call me, you call back.
Absolutely.
I called him back, and he said, did you understand what I was telling you last night about an acute intubation for an acute condition and a chronic condition? I said, yes, I did. He said, okay. He said, I've just gotten off the phone with the nurse, and your father is becoming septic. You may want to rethink that decision. I'm happy to answer any questions you have. Again, somebody outside the hospital system who was not allowed to visit my father because he did not have privileges at that hospital. So he could come as a private person, but he could not come in his medical capacity. And I understand that there's a need for rules and regulations.
Yes.
But
one of the comments that stuck out to me was when they were prepping me for surgery, and I don't remember, I think it was somebody with anesthesia, or who knows. They ask you the same questions 150 times. What's your name, date of birth? What are we doing? Who's your primary care doctor? And they stumbled on my primary care doctor. They're like, well, they said, well, is he with Multicare, which is the big system where I was having the surgery done? And I said, no, he's independent. And they're like, you can do that? He actually said, you can do that? Even a lot of healthcare professionals do not understand you don't have to work for a healthcare system. It's legal
to be on your own
and ethical to be on your own. I just about fell out of my bed when he said that to me. I'm like, yeah, it's fine. You can do it.
Mm-hmm. And a lot of practitioners are happier as independent physicians because they can treat their patients. They can be paid a fair wage. They don't have a lot of paperwork. It is not the be all and end all. It is never going to work system wide. But for patients that have access, and it's not necessarily expensive, employers can offer it, whole 9 yards, conversation for another day, it can be incredibly helpful. We see less medications, less specialty visits, healthier people.
So I think that one of the main themes that we're both hearing, we both experienced, is the lack of adequate communication.
Mm-hmm.
And I don't think that should be such a heavy lift, because the healthcare systems have invested in a ton of money into all these systems to eliminate the communication, because it's software driven, it's AI driven. They're like, well, you're going to get all this information you need. But it seems to me that a 15-minute follow-up phone call post-surgery, could be a nurse, medical, I don't care who it is. Doesn't have to be the doctor.
Correct.
My vet calls to check on my dogs after they've had a procedure.
But your doctor didn't call to check on you after your hip, right?
No, nada. And when I actually did need to call because I had a little minor thing, I call the number. There's not an option to speak to the doctor or the nurse. That's not an option. So of course I'm pressing buttons until I finally get a live person. And I was able to speak to a medical assistant who relayed my information to 3 or 4 people who relayed it back to me. They gave me the wrong information, which exacerbated my problem. And thankfully I was able to get an appointment to go in, and they're like, oh, I guess we shouldn't have told you that. But it's just like this little bit of time could save all this waste in the healthcare system, because I had to go in, I had to take their physical time, I had to go through their record system, et cetera, et cetera. Mm-hmm. So I think that we're counterintuitive on how we are addressing some of these issues. I mean, sometimes old-fashioned isn't the worst way to go.
It's not. And I think context is so important in healthcare. I mean, we're not widgets. Last time I checked, we're not widgets, and people are different. Their body chemistries are different. Their tolerance for pain is different. they heal differently. There's all these things, and there isn't, it's like, yeah, okay, just go to the portal. Well, even going to the portal might be okay if you could understand what's in the portal, right? But if you don't understand what's in the portal, then you're stuck. So what do you do?
Yeah.
Now, for me in the hospital, I just chased people down, or I simply stood in front of them. Um, I don't really recommend that. I don't even understand why that's necessary. But you have to have somebody, you either have to advocate for yourself, and I'm sorry if you're under anesthesia, probably not the best time to advocate for yourself. So you need somebody to advocate for you.
Yeah, it's we spend so much time in our jobs putting together access to quality care, fair pricing solutions, et cetera. And even with all that work, we still can't, for the most part, change the patient experience.
Correct.
And that's where a lot of frustration, we get a lot of frustration and pushback from patients because they're like, well, this happened. And like, it can happen. It can happen anywhere, anytime, for any procedure, because that's the way the system is built right now. And I don't know how we address it, but at some level, we need to address the patient experience, because if they can fix that, I think a lot of it's going to follow.
Correct. A lot of things would go away. And I'm going to give you two examples that I think are things that we need to think about. So in my surgery from about 11 or 12 years ago, I lived by myself at the time, and I had great support. I got myself to the surgery. One of my girlfriends picked me up. People checked on me throughout the weekend. I really was fine. It was not a big deal, but I wasn't allowed to drive. At my pre-op appointment, I asked the doctor, I live by myself. Do I need pain medication? Do I need anything? But no, you're just going to need acetaminophen. You'll be fine. The last thing he did before they put me out is like, okay, I'm going to write you a script for whatever, Demerol probably. And I'm like, what do you mean you're writing me a script for Demerol? And he said, well, usually people are happy. I said, I asked you this in your office last week. I said, I live by myself. I'm not allowed to drive for 48 hours. How do you think I'm going to get that? Like, it never entered his head. But those little problems are the biggest barriers to care, no matter what side of the equation you're on.
Right.
It's well, who was going to go get it for me? And it was a narcotic. Nobody could pick it up for me. So, we need to think about those things. Direct primary care, if you have a primary care physician, typically those conversations are a little easier to have. And then the other thing is, I was reading an article about a family that had an experience similarly to mine in a national newspaper. And this weekend, I was reading the letters to the editor. And there were 4 or 5 letters on this subject. And most of them were from people that had had a similar experience and were like, we need better laws to help people die with dignity. Because I can tell you, my father had no dignity in his death. And apparently many people, their parents, their spouses, their siblings, their children have no dignity in death. And that seems terrible to me. There was one letter from a physician who was commenting on the medically assisted in death law in New Jersey. And he said, well, there's some problems with that law. If a patient doesn't want to live anymore, then they can withdraw they can refuse food and water. So now we're going to starve, we're going to dehydrate people to death? Really? That's the answer?
Yeah. So I believe that for the most part, there's nobody in the healthcare system that doesn't want to provide a good healthcare experience.
I agree.
I mean, when we discuss these things, it's not to point a finger or say, you don't care about people. I believe they do. I believe that you do not go into healthcare if you don't care about people. I believe that that is fundamentally true. But I think we've gotten so caught up in these big machines, and we keep adding parts to the machines that take the people out.
Mm-hmm.
and at some point, we've got to reverse this trend and put the people factor back in because it's not working.
It is not working, and our costs are going to continue to escalate, and people are going to have worse and worse outcomes. And I think, yes, my experience was a death experience, but your experience was a patient experience. And, you know, you're alive, walking around, exercising, going to PT, doing all the things, but that experience could have been simpler, and you could have avoided a few pitfalls with more conversation about what was not just what was going to happen to you, but what to expect after the surgery. It's not, you'll be fine. Somebody just cut you open and replace part of your body. You may be fine, but it's going to take a little bit.
Well, the part that they don't talk about with a joint replacement is not only do they saw off 2 pieces of your bones, they cut through your muscles and tendons and skin, and there's a lot of healing around that. Has nothing to do with your actual joint.
Right.
And so, but no one ever talks about that. It's not in the handbook. It's not in the online class. It's not in your portal. It's just, oh,
yeah.
Well, and again, it would be nice to know, hey, this is normal.
Mm-hmm.
Some people experience this, but you get crickets. Or at least I got crickets, and that was extreme. Yeah, and you go to call and you can't actually speak to a real person.
Right.
So I think we've covered this topic adequately well. Allison and I really feel passionately about this, and I think that we're going to probably pop on your screen a little bit more frequently to jointly discuss some of these issues and potential solutions. I think it would be great to talk about primary care in more depth, maybe the next time we get together, and how direct primary care, or if you don't have that, how you can create a better relationship and a better opportunity with your primary care physician you have that may be in a hospital system to be a better advocate for yourself. How do you feel about that as our next topic?
I think that would be a great next topic.
Okay. Well, thanks everybody for tuning in. Next time we might even have a title and maybe a different background, but we kind of just threw this together because we've been talking offline. I'm like, we should talk about this to the public. So thank you for tuning in, and we will see you again soon.
See you soon.